So, from a combination perspective, still we're seeing the really pivotal importance of a retinoid. And I think this would be a good standpoint to actually talk about oral retinoids and the history and the use of Accutane and the different formulations. So, Emil, can you touch on that?
Isotretinoin has been with us a long time. And we do know that it diminishes sebaceous gland secretion, and we think that that's part of the mechanism. We don't know the whole mechanism. We don't know why there's longevity with this. We do know that it's a product that works, and it's probably, when you have severe acne, it's the go-to product in the marketplace. So again, it's with us a long time. We don't totally understand it, but it's a drug that's indispensable for us to treat our patients with more severe acne. Certainly when the drug's been available, and we do know there's a lot of controversy about this. Issues with inflammatory bowel disease is brought up. There's really conflicting data. It doesn't look convincing that it's a cause, but it's still mentioned. I think we ask, I think we're careful. The same thing with depression. There's not a lot of good data to say that it's necessarily a factor here, but at the end of the day, if you talk to your acne patients, you're gonna find out that a lot of them are depressed beforehand. And especially now in the pandemic, it's a big deal with teenagers, so it's always good to ask. If there's depressed, I get them under control before proceeding, just as a point of caution, not necessarily as a point of data. Growth plates do concern me, and this was mentioned, and the younger patients, I have some reticence, to be totally frank with you, about putting patients on it. I will try my damnedest, I will mention that to them, but at the end of the day, I don't think we have a lot of convincing data that one go around of this is going to be an issue. Pseudotumor cerebri is a big deal, especially if they're on birth control, so we should be aware, but never had them on tetracycline antibiotics with this, because that certainly would exacerbate this. And then lastly, the fulminans flare, that is the flare that can occur on someone on the drug. And I'm very, very cautious in my more severe patients. To be totally candid with you, and I'd like to hear what the others have to say, I start really slow in my severe patients, maybe 20 milligrams, maybe 10, and then I work my way up. I might have them on it longer, but I do not want to throw these glands into an apoptotic state, have all the contents dissolve, and cause an intense inflammatory response. So I go really slow.
That's exactly what I do.
Diane and Linda as well.
Yeah, I was actually trained that way in residency years and years ago, to start at half dose, but in those that are very, very inflammatory and very inflamed and cystic, I'll start even less than half. And I do gradually titrate up, and then I leave them on it longer.
Yep.
And
So,
sometimes the addition of prednisone as well for those really inflamed ones at the very beginning.
So
yeah, I mean, I didn't have that training. I had to learn the hard way, and it was not pleasant in those few patients.
As somebody who's married to a pediatrician, I think there's a lot of misperceptions in just the general medical community about Accutane. And first of all, I think that many people are not actually treated to the full dose, 120 to 150 milligram per kilogram. Sometimes insurance companies really pigeon you into doing a 5-month course. And when you're starting low, that actually can be a bit problematic, because it's going to take longer than 5 months. And then secondly, some of these people actually need a second round. I have a kid who was on Accutane already and is now on Accutane again. And it's not a panacea. We may need to consider it. And people that may be older, I have a family member who's on low dose Accutane for a longer period of time. And these are all legitimate concerns that we have. And we really want to treat these people effectively and appropriately, and not just that 5-month interval where insurance seems to tag on to the prescription.
And make sure they take it with food, because a lot of people now are doing intermittent fasting. They're having smoothies, and basically it has to be taken with some fat with a meal. Otherwise you don't get the absorption and it doesn't work. And I can often tell that by looking at their lips. If their lips aren't chapped, they're just not absorbing enough.
And the problem is, we tell them, we speak out of both sides of our mouth, because we tell them, watch your fats, because we watch your lipids. However, if you don't, the way that isotretinoin was studied was with 1,000 calories, 50 grams of fat with each meal. Nobody's going to do that. So there is the Lidose formulation and the micronized technology that both can be taken on an empty stomach. And, a lot of people need more than one dose, and probably because it wasn't being absorbed,
Yeah, and
I
I'm
mean,
trying to put the patients on that. I love that low dose, and you know, you have to do the math because it's a, you know, it's a lower dose, so the 20
For the
milligrams
micronized.
becomes the 16 and the 30 becomes the 24. But it does have that encapsulation that's lipid based that absorbs quickly. And I think that I really do need that for a lot of my patients. Obviously, we have to try to make sure they're getting it because sometimes they're not getting it when you're ordering it. And that's a whole nother discussion.
So
no, it's very
Linda,
hard. Yeah, it's hard because, you know, another prior authorization that needs to be available seamlessly. This price differential is crazy. It just makes the practice of dermatology that much harder. And I, quite frankly, can't do a prior authorization for every topical and oral medicine we have. So we try to do the best we can with a fatty meal, like Linda said. I think that's a really good point.
So we've talked a little bit about some of the discussion points or controversies about Accutane, and I want to get back to something that we brought up briefly, but really explore that is really the whole antibiotic stewardship movement. You know, as a Mohs surgeon, as well as a cosmetic dermatologist that does a lot of laser, I'm very careful about prescribing antibiotics. I don't put people routinely on prophylactic antibiotics after surgery or after laser procedures. There are people who flare after a fractional type laser and get some acne, and sometimes we go to low dose doxycycline for that. And if we look at other uses of doxycycline, you know, that's one of the few things from a community acquired perspective of MRSA that people actually can still take. And so as we use doxycycline, we think about, you know, are we actually causing resistance in the community if we put people on doxycycline for long periods of time for acne? So Linda, can you talk to us about antibiotic stewardship and some of the concerns about resistance? And then really with antibiotics in general, people have been concerned about gut flora and inflammatory bowel disease and those types of issues as well.
Yeah, there's so much to talk about, as you mentioned, Joel, with the oral antibiotics. And we're learning as we go, and we're learning to be better physicians and take better care of our patients. One of the interesting things you mentioned is the association between inflammatory bowel disease and isotretinoin. As we've studied that, we've actually come to understand that there's probably a stronger association between oral antibiotics and inflammatory bowel disease. And we see that even in young children who are exposed to multiple courses have an increased risk over time. We've seen an association with doxycycline. So I don't think that oral antibiotics for long periods of time are without its risks. So I do tell people that when we do clinical trials, we always do it with combination therapy, ideally. And I think the best course of action is to use an appropriate dose oral antibiotic with a topical, a potent topical, leave that patient on when we do the clinical trials. And Emil kind of alluded to this. We looked at some with fixed combinations. We only studied them for 3 months. That's probably not enough. But I'd say 4 or 5, then withdraw the oral antibiotic and continue on the topical therapy, because it's not oral isotretinoin. You didn't cure them. They are going to flare up again if you withdraw all therapy. But I think short courses.
Yeah, Linda, you know, you bring up a great point about the duration of therapy. And if you look at the data on Epiduo Forte, they did a really great job. They showed that at 3 months, that 12 weeks, the clinical trial, we got the clear to almost clear 33%. At month 6, it was closer to 2/3 of the patient achieved that. So when I see my acne patients and they're there even at 12 weeks, I say, you are just beginning to see the effects of these drugs. It takes a long, long time. The other point that I think is extremely important to know is the biggest problem when we look at antibiotic stewardship is, what are we using topically? Do you know that the most common topical agent for acne is not a retinoid? It's clindamycin, for God's sakes, and single agent clindamycin, not BPO clindamycin. So we've got to do a much better job of educating our colleagues that clindamycin is not a good agent to use as a single agent. You're just putting out a resistance problem.
Yeah, and the idea of utilizing a benzoyl peroxide is such an important point. And a lot of people feel that, you know, they prefer to use a wash as opposed to using a leave-on gel, and that's fine. But you have to educate patients that I tell them, put it on before you get in the shower. Chest, back, you know, we know they have to have some short contact. It's not just to breeze by their skin. So put it on before you get in the shower, put on everywhere that you're affected, let it sit a few minutes, and then rinse it off. So if you can incorporate a benzoyl peroxide at some level, you know, leave-on gel is going to be better, but if you can utilize at least a short contact wash, that's better than nothing.
Yeah, and the two best ones in the marketplace are benzofoam and the penoxyl foamy wash. You stick them on for a few minutes before the shower and wash them off. Very convenient.
Honestly, that's been my approach as well, because for many people, they're worried about bleaching fabric. And, you know, if you bleach a towel or you just start off with a white towel, that's certainly better than bleaching your pillowcases and your bed sheets and some of your nicer clothing. So I think that that's really a helpful approach and certainly enhances the contact time. So from, you know, discussion points and controversies about Accutane to antibiotic stewardship with antibiotics and topical formulations to minimize, to really minimize and try to minimize resistance. Diane, can you talk to us specifically about some of the discussion points with spironolactone? I think historically people were worried about breast issues, and now really the only real issue seems to be some breast tenderness. Historically, people actually monitored potassium. There was a recent study that showed people continue to do that, but it's probably not necessary. So take us through some of the spironolactone points.
Yes. I mentioned spironolactone earlier, and I use it very often in patients. And I'll use it with the antibiotic and then try to get them off the antibiotic sooner in the essence of antibiotic stewardship. I find it to be very safe. Patients tolerate it well. I do not monitor for potassium. In a healthy person with the doses that we're using, it's usually not an issue. I did have one patient had recently a mildly elevated potassium who happened to be on spironolactone, but it was mild and nothing consequential. We know now that we really don't have to do this for patients who are healthy. If they have renal disease, potentially you might have to do so, but I find it to be safe. In terms of the side effects, maybe a little bit of breast tenderness, but that's very minimal also. Certainly we see more of those side effects with the estrogen moiety from the birth control pill, the tenderness, and of course the risk for thromboembolic events and certainly headaches and breast issues. So I would not give the birth control pill to anyone with a personal history of breast cancer. If there's a family history of breast cancer, I think that there's a discussion to be had with their other doctors. It is officially not contraindicated, but in terms of giving the pill to those individuals, I would want to speak with their doctor. But I don't have an issue giving spironolactone with respect to that. And studies have shown that there is no increased risk for breast cancer, because remember, in the rat studies led to tumors in the breast, and that led to the black box designation. But in humans, there has been no increased risk shown with spironolactone.
Diane, I just want to, I'm really a conservative physician, and as somebody who does clinical trials, I'm not sure what a young, healthy patient looks like, because everybody that comes into our trials are supposed to be young, healthy people. Then we do blood work and they're not young. I mean, they might be young, but they're not healthy. So I tend to have a practice in any patient in whom I'm considering long-term systemic therapy. I want to see baseline labs. And I don't necessarily have to be the one that drew them, but in the past 6 months, I want to see a complete blood, biochemistry profile, CBC, LFTs. I want to see who you are before you start on my therapy.
Well, yeah, even antibiotics, in theory, you might have a low white count or a discrepancy there. But I think a baseline isn't a bad idea, but I don't routinely follow potassium in the spironolactone patients. But it gets checked, for instance, in the patients who are on isotretinoin and simultaneous spironolactone.
And one more thing about this, there are a lot of foods and drinks that have a high amount of potassium, including like coconut water, fruit juices,
soda.
They shouldn't be taking Bactrim with spironolactone. There's a lot of little key things that, you want to make sure you just call out to our spironolactone patients.
I tell them soda, and I tell them that's another reason to drink a lot of water anyway.
Emil, you've been really involved not only with acne clinical trials and treating a lot of acne patients over the years, but as a laser person and as a procedural dermatologist as well, you've been involved with many important initiatives. So from an acne perspective, we've had for a number of years photodynamic therapy. We can consider using red light instead of blue light to penetrate deeper. Rox Anderson did a cover article in Journal of the American Academy of Dermatology with Fernanda Sakamoto a few years ago. you know, that's certainly an option for us. And it's really exciting to really think about specific acne lasers that target sebaceous glands. And you and I are involved with those clinical trials right now with the cure. So talk to us a little bit about procedures really focusing on acne.
Yeah, you know, really, when you're looking at isotretinoin, again, probably the most durable responsive drug we have, you understand that this centers around sebaceous gland damage. And the question is, can you damage it? Can you destroy it? I don't know if we want to completely destroy it. Certainly we want to damage it and alter it so it's not overproducing. So again, the idea is, can we use selective photothermolysis, that is a laser, to do this? And we would have to target the endogenous chromophore sebum. Now we know that there's other procedures out there, that is PDT, gold nanoshells, that could potentially do it. But again, the idea is, can we use a laser? And if we look at the spectrum of absorption, we see sebum in the red here. There's a small peak at 1726. It's not a big peak, it's a small peak. And the idea is you can get preferential absorption of sebum in the red over water or in the blue here. And so as a consequence, you can maybe treat sebaceous glands and damage them. So we've been exploring for the last 5 years a device, and this is what sebaceous gland damage looks like. In the center here, we see a sebaceous gland associated with a hair follicle. We can see a pink discoloration of the entire sebaceous gland. Without damage to the hair follicle to the left, and we could see only a partially damaged sebaceous gland on the right. So the idea is we can selectively do this. And these are some more pictures of selective damage on the left, where we don't damage the underlying collagen and histology, we only damage the sebaceous gland. And these are treatments that we've done over the last number of years. And again, a closer up view of what happens. We see these ghost-like cells, we see some clotting of the blood vessels, and we don't see damage to the surrounding collagen. So this is an exciting way that we've developed to treat sebaceous glands. And what we started with was a situation on the left there where we had a thermal camera, we had air cooling, we were monitoring every pulse, and now we've miniaturized it, and on the right we have a thermal camera looking on as we treat, and Joel's been treating with us as well, doing this. And again, every shot gets monitored by a thermal camera. We're right on, know where we need to be. We know what temperature we have to be, because it's easy to give too much laser light and do damage. So we have a way of monitoring this. And when we look at this, this is what the system now looks like. This is 5 years down the road, and we have a system, and we're in FDA, in essence, phase 3 clinical trial, pivotal trial. The problem is COVID made it a little harder to do this. These are some of our early patients where we treated a small square here. You can see a before. This is significant acne. You can see an after a 12-week follow-up. We have follow-up long 3 and 6 months, and now we have year follow-up. We're treating patients with moderate acne and to severe acne, and we're seeing improvement. So again, this is something very, very encouraging. We also have high-dose red light PDT. This too can damage sebaceous glands. These are the work that was done at the Wellman by Roxanne Anderson and Fernanda Sakamoto. And but unfortunately, this is what people look like during this laser treatment. Too much downtime because of epidermal absorption, which you can get patients clear, but too much downtime. We also have gold nanoshells. And again, these seem to work to a point. There's also ICG that we've used, but again, not commercially available. The gold nanoshells were till the company went broke. But the damage to them is only superficial. We can see here it gets in there, it gets in the infundibular region of the follicle, it damages them. Acne does get better for sure, because if you clear the infundibular region, it gets better, but it doesn't give you the durable response. So with that said, I think that we are at the point right now that we're on the cusp of having a device that we can say we can treat our patients with acne with, and it's certainly going to be welcome in the market.
You know, from this acne laser 1726, a cure, studies going on right now from pre-COVID data that you did all this, Roxton, you really came up with this and other people have been involved. It got the CE mark of approval, which is very exciting. And now, right now, we're doing this study with you and Roy Geronimus and myself. And it's exciting to actually have a treatment for kids that really does not involve a whole Accutane discussion with parents. So we'll see where this leads, but I think that there's a tremendous amount of optimism behind this as another amazing Rox Anderson invention.
Yeah, it's not only kids, to be frank with you. It's adults and adult women. I mean, these people are plagued by this, and I must say we have to credit the people that Rox and Fernanda came up with the idea, but the idea was easy compared to the execution. It's the people, the engineers, the scientists that came up with this whole methodology to do this. This has been 5 years we've been working on this, and we're making headway, but it took 5 long years to get to this point.
So from a perspective of procedures, not all dermatologists out there do a lot of laser work, and not everybody does photodynamic therapy in their practice, but we all have available to us things like chemical peels that we may use for actinic keratoses with TCA. We may use chemical peels for pigmentation with glycolic or Jessner solution. So Diane, you've done some work, and I've worked with you on a number of publications about specifically looking at chemical peels for acne, like salicylic acid peels. So can you talk to us a little bit about your approach and how you incorporate them into your acne regimen to really get better results?
I actually love using salicylic acid peels for my patients with acne and actually rosacea also. Salicylic acid is a very inexpensive product, so any dermatologist, even someone starting out, could certainly use this from the get-go. It does not involve purchasing a big device. I usually use the 25% formulation, and salicylic acid is lipophilic, so it gets into the sebaceous follicle as opposed to glycolic acid, which is hydrophilic and goes through into the dermis. Salicylic acid is lipophilic, it gets into the sebaceous follicle. When I perform a salicylic acid peel on a patient, it removes the surface oil and debris that's clogging their pores. It removes the surface oil from the surface of the skin. So after the peel, actually immediately after, their skin almost looks smoother and tighter. Their pores look smaller. We're not making them smaller, but they appear a little smaller. And salicylic acid is related to aspirin, so it's actually also anti-inflammatory. So the patients just look and feel a little bit better because it is removing that oil. It improves the tone and the texture of the skin. Dr. Grimes has done some nice studies showing that, where you get an improvement of tone, texture, and the look of pores and the look of oil. And therapeutically, it might be doing a little bit, but it's nice to get your hands on those patients. They feel like you've done something. They look a little bit better, and it gives them almost a jump start to get motivated to use their regimen at home. And, since compliance is key with acne, doing this for them gives them a little bit of a start. But I find it's also helpful not just for the active acne and oil and pores, but as you mentioned, it's helpful for pigmentation also. So if you're dealing with someone who has residual post-inflammatory hyperpigmentation or even post-inflammatory erythema, I like using those salicylic acid peels. I've also had a lot of luck using the Jessner's peels in patients who have active acne and acne scarring.
So from my perspective as a dermatologist, married to a pediatrician, I have 3 kids that have acne. My wife has some acne. I have some acne. There's things that we do and recommend to our patients that we also actually are doing on our family members. And from the perspective of what you just mentioned, it's very common for my family members to be at my office doing dermal infusion, microdermabrasion type of procedures to really open up some of these pores. And then we can, for maintenance therapy, a lot of times I'll just do a salicylic acid peel at home. They're literally laying flat next to the bathtub so something doesn't drip down. But I'm doing salicylic acid peels. And then, one of the things that we incorporate in our practice, and I'll have Emil touch on this, is photopneumatic treatment. And I still think there's a role for that, and I think it works. We have the TheraClear device, and basically it's IPL with suction, and it really targets the endogenous porphyrins. And there's also the isolase device. So Emil, can you talk to us a little bit about photopneumatic?
Yeah, photopneumatic therapy is interesting, and it does provide a short-term rapid improvement of acne, no doubt. We did a trial once where we studied a combination of a retinoid, benzoyl peroxide, and compared it to the TheraClear device that you're talking about. And over the first 5 weeks, it worked better than our acne treatment. However, at month 3, they were equal. And after that, the patients that were on the topical therapies did better. So yes, it does give you a temporary quick fix, but at the end of the day, you got to look at the money spent. Is it worth it? Can people afford it? Because it's not covered by insurance. So I don't know. I had it and I quit using it because patients didn't want to pay. And if they wait another month or two, they got their topical therapy that did it all. So again, I'm much more, economically driven, about that, but it does work quickly, no doubt.
I was very careful to say for flares, because I think that what we actually see as dermatologists is we prescribe a regimen to patients, and then we're asking them to really be patient for 2 or 3 or 4 months to really see those improvements. And when people flare, if you incorporate photopneumatic treatment like we do with TheraClear in our practice, you can actually get really better compliance in my perspective, because these kids believe you, or these young adults believe you, that you're going to make them better because they see it more quickly. So I think if you're incorporating these treatments for flares and you have people on a topical regimen or even an oral regimen, you're actually going to get more compliance and more buy-in from them about this. So the problem with some of these studies is they're standalone. You're comparing one thing against a combination, and in real life, we're actually throwing a lot of things at them, and that's what we're doing, in our practice. So
Joel,
I want to take this.
I'd like to just you mentioned dermal infusion, and I'd just like to say that is a great method for men. Men love the dermal infusion. The idea of sucking up all the oil and cleaning out their pores. They all have this very sebaceous, oily skin. Not all, and I'm not generalizing, but a lot of my men patients have large pores on their face and on their nose, and they just love that treatment. They love the instant gratification. They love having something done, and it sucks out all the oil. And I think that's a great treatment for men who have sebaceous, oily skin.
Emil, you've treated patients with acne and acne scars for many years. I do a lot of acne scar treatments as well. I think really one of the great things about acne scar modality treatments is the fractional bipolar microneedling treatments like the Genius RF and the Morpheus 8 and those types of devices with insulated needles, really treating at the area of the pathology. Other things that are really simple and effective are subcision, and then of course, fractional lasers, whether it's non-ablative and a series of fractional lasers, or ablative fractional, and these kids have downtime. And oftentimes it's sort of an amalgamation of all of these acne scar modalities.
So, what treating acne scar is really all about. It's all about creating a new injury that will be enhanced by healing. And again, whether it's a retinoid, whether it's a laser, again, or a chemical peel. Now, I'm not a big fan of chemical peels because I don't have control as much as I do with my lasers and lights. I know what I'm doing with my lasers and lights. And certainly fully ablative treatments work, but there's too much downtime. Fractionally, ablative and non-ablative are really the way to go. And the ultimate in the non-ablative treatment is the fractional picosecond device, which delivers an epidermal injury only. And in this epidermal injury, we have a rejuvenation response that's pretty remarkable. So at the end of the day, what we do is we wound the skin one way or another to get some significant improvement. And I also like microneedling, as you said. And so we have developed techniques where we use RF microneedling, and we do that. And then we also do things like low downtime CO2, which is a high peak power, low energy treatment, or a thulium treatment, which you've done as well, Joe, or fractional picosecond. The beauty of these treatments is you do them, and you could see here right after the treatment, the patients are a little red. 24 hours later, the patients look okay. They're functioning. There's not a lot of downtime. And we also use fractional picosecond with the microneedling, same day, same time, and we can get improvement like that. With these, I'm constantly also using topical retinoids because there's been great data generated by Siwan Kang showing that topical retinoids, adapalene, or using tazarotene certainly does improve acne scars as well. So I think looking at procedures that help, looking at procedures that are relatively low downtime, whether it's RF microneedling, microneedling thulium, microneedling low CO2, microneedling fractional picosecond. I think there's ways to incorporate a multi-treatment approach at monthly intervals to see improvement of acne scars.
So with this patient that you have up right here, I would approach this patient, I would say, listen, we have non-ablative fractional modalities that can give you a day or two of downtime, whether it's a thulium 1927 laser like the Lace Ultra or Moxie. Or some of the other 1550 or 1540 devices. I think we can give you a day or two of being a little bit pink. Sometimes I'll do subcision with an 18 gauge no core needle into these spots, and they look pretty good a couple days later. And then there's the patients who really want to come in and they want to see major results, but they don't want to do this a lot of times, and they're okay to do downtime. And my approach is very similar to yours. I'll use radio frequency, bipolar fractional devices with actually ablative fractional devices, trying to give them that synergy. I'll still do some subcision in the area. And as long as they have downtime, you know, this is a great patient where I think a little bit of the cross technique using high concentration TCA for some of the really more ice pick areas up in the lateral canthus and on the zygoma would be really helpful as well for this particular patient. So I think the combination of many of the things that we do is important. And for that patient, because they're type 4 skin, you know, I would actually use a fractional ablative erbium more focally, just to try to go deeper into those spots. And then you can sort of blend out with either fractional erbium or fractional CO2, but the deeper component, I would use erbium.
Yeah, but Joel, what I'm showing you here is RF microneedling with CO2, basically the same as a thulium. It gives you the superficial, it gives you the deep wounding. Look at the downtime here. There is not much downtime, and you're doing both areas. So at the end of the day, I think we could do a better job. The problem is it's not in one treatment. It's a series of 3 to 4 treatments. I don't know. What do you feel, Diane, about this?
I actually have a Fraxel device, which I love, and it's really my workhorse device. So when I do have patients with early acne scarring, certainly not severe, with early acne scarring, I do like using my Fraxel, and I use the 1550 wavelength. If they do have more severe scarring, I will refer them out for more of the ablative procedures.
So, you know, from my perspective, I think we have the really low downtime, and that's great to see what your approach is really with the fractional CO2 with the RF microneedling. That synergy can be really helpful. So, you know, the patients who really want to look okay in a couple days, and then the patients who are good for, you know, maybe 4 or 5 days, I'll do a lot of halo, which is 1470 plus 2940. So 2940 getting more superficially and really more of a wound, and then the 1470 going deeper, really where the pathogenesis of the acne scars and the tethering is. I'll still incorporate subcision, and then for the people who want more specific downtime, then the RF microneedling plus even the fractional CO2 as you showed. But it's great to actually see how we're all sort of modulating these techniques based on downtime. And I think that there's a lot of options we have. Wow, it's been great having all of you guys join us for Scientifically Speaking. Really, there's a lot of innovations in acne. There's ways that we can really help our patients. And I'm excited about what's on the horizon with laser treatment of sebaceous glands and acne. And I think putting this all together, I think for people now who have significant acne, there is definitely modalities that we can try to minimize their acne, make them feel better about themselves, probably cut down on the rates of depression in these people that have acne, and then hopefully prevent them from getting scarring. But there certainly is a lot of modalities that we can do for the treatment of acne scarring specifically. So thank you very much for sharing your insights with us and for joining us on Scientifically Speaking.